So good day, friends. This is Dr. Bob Hamilton, and you have tuned in today to the Hamilton Review, where kids and culture collide. Thank you for making us part of your day. It means a lot to me. And so if you like what you hear, make a note, send a note to friends, or write something nice on Apple Podcasts, wherever you get your podcasts. So today we're going to bring back a friend and a colleague of mine who has a little bit of a little addendum, if you will, to a previous conversation we had. My colleague's name is Suparna Jain. She was on my podcast about a month or two ago talking about melatonin, the use of melatonin for sleep in children. And shortly after we finished the show, she got new information. So Dr. Suparna Jain is a pediatric endocrinologist here in Santa Monica, California. Suparna, welcome back to the Hamilton Review.
Thank you, Bob, so much for having me back again.
Absolutely. I would love that I learned so much from your previous show. I will tell you that you're a gem, and could have you back every week, frankly. But I would like you to kind of expound on something that we shared after we recorded our first show about some other information that you were that you can expound on in terms of the use of melatonin in kids. So the microphone belongs to you, Dr. Jain.
Thank you, Bob. So last time we had spoken about melatonin, its use, and the fact that it is really a hormone, though in the United States, it's viewed as a supplement, and as such isn't regulated in the same way. And during this pandemic, I think a lot of parents experienced sleep disruption amongst their children, and there was just an explosion of the use of melatonin, even in very, very young children. And as a result, the reporting within the last 2 years was that there was a significant increase in emergency room visits and even hospitalizations of children who had taken too much melatonin. There were even a couple of infant deaths associated with this. Part of what comes up here is that melatonin, as we said, is a hormone, and its dosing can be difficult to fully understand because you have to tailor it to the individual. The medication in the US is not regulated as the same way as the FDA regulates other products. So there may be actually variability of the active amount of melatonin in a product. So it may be labeled as saying it's a 1 milligram, but there could be up to a 40% difference in the delivered dose. And the chewables apparently are more susceptible to this degree of variability. And the chewables are probably the things that are given to infants and toddlers.
Sure.
So that's a concern. Some of the problems that can occur with melatonin overdose is that melatonin's breakdown product is serotonin, which is a neurotransmitter. And serotonin syndrome is due to too much serotonin being around in the bloodstream and in the brain. And this can cause agitation and confusion. It can cause a very high blood pressure. And so these are things that could then lead to significant effects of your brain and of your cardiovascular system. The American Academy of Pediatrics recommends that a child that is under 2 years of age never be administered even an over-the-counter medication unless it has been reviewed with the child's physician. And I would go further to say that even under 6 years of age, if it's a product that's never been used, it's not something like Tylenol or ibuprofen that you're using for fever, but that may be a hormone or a supplement, it should be run by the child's treating physician.
Sure, I agree. So, this is disconcerting to actually, because this is something new that I was looking at melatonin. We talked about it, and we do use it in our office. We use it not usually for children under 2 years of age, for sure, but we do use it for kids who are in the 3, 4, 5 range. For kids who have difficulty sleeping, is more commonly used, I think, in older kids and older people in general. But what you're saying here is these overdoses, are they happening in younger children, or what ages are these happening?
It is more in younger children where it's a parent that's administering it and may not realize that the dose is too high. It's also possible that if they haven't had a good effect from it, they're trying to give an additional dose. Sometimes if parents are, sleep deprived and one parent is in charge for a while and then another parent is in charge, they may not know that a dose has been given and then another dose is given. So it is more in the younger children that we're seeing this.
And the number of milligrams you're talking about for overdose, is there a threshold? Because usually the dosage is pretty low. It's like 1 milligram,
Right.
maybe less than a milligram. What kind of dosages are these kids ingesting that are causing the overdose?
I didn't see any specific information on what the doses were like. Let's see, but sometimes the doses could be as much as 4 times the amount that would be normally prescribed.
Okay, and I regard 4 times the amount is not that much. I honestly don't. I mean, I'm usually, you think about overdoses like 10 times or 20 times, but 4 times is actually a pretty tight window. So I think this is very important information, friends. If you are using melatonin, you have to really be very, very careful about how much you're actually giving your child. So early indications are jitteriness, irritability, any other signs that you can share with us?
Some tremulousness, because that's part of the central nervous system. Those would be the main things, especially in a young child that's not able to express what they're feeling. Looking for that irritability or confusion is the main thing.
Would it also cause wakefulness? In other words, rather than having the kids going to sleep, it would actually have a paradoxical effect.
That's exactly right. Yes.
Okay.
So just like other medications like Benadryl, which is an antihistamine, and that can also have serotonin-like effects. We know that children under 3 years of age can have paradoxical reactions with Benadryl. So rather than being sedated, they can become agitated and hyperactive. They can even hallucinate. Yeah.
No, I've actually recommended times where and I don't think every kid has that kind of paradoxical reaction, but I've certainly had kids who have had that. And, parents, commonly, if they're flying to Europe or something, they will say, can we give some Benadryl? And I usually go, yeah, you can, but I always tell them, try it out first, because even low dosages, some kids can actually have that paradoxical reaction. And I don't want parents to be swearing at me all the way
on the plane,
on the Atlantic Ocean. They're saying bad things about me personally.
Yeah, I always tell them if they must use something like Benadryl for a flight, that they have to try it on land first.
Yeah. Okay. We agree on that recommendation. So if those of you who are listening, if you're planning on an international trip, think about that. Okay. Try it before you actually get on an airplane, and don't use a big dose, by the way. Okay. So I thank you for that. This is a very important update on the use of melatonin. I think we all need to take to heart that this is not, this is a substance which is a real hormone, and it has, as Dr. Jain has mentioned, hormones can have an effect all through the entire body. It's not just one location is having this effect. It has an effect other locations as well, because it is a hormone. So, Dr. Jain, I'd like to just kind of, for the last couple of minutes of this conversation today, I'd like to switch gears a little bit in a big way and talk about something which is definitely in the news today, and that is the fact that there are transgender clinics which are opening all around the country to deal with young men and women who are going through a transition, gender transition. And one of the things that I think that I'd like to have you share is what actually happens. I know that I think it's important that people just understand kind of the mechanism from an endocrinological perspective about what happens in these transitions, and both for girls who are transitioning to become boys and boys who are transitioning to become girls. So just first of all, the mechanism of what actually happens and how these things progress.
Many young people who are going through the process of understanding their gender identity, as they approach puberty, may find that time and the body changes that are occurring very disconcerting. And they may at that point just feel, in conjunction with their treating physician, that they need just some time to sort through these thoughts and feelings. One of the first lines of treatment that are used in that setting is what's called puberty blocking or pubertal suppression. This involves being given a medication that looks just like the body's own gonadotropin releasing hormone, which is a hypothalamic hormone that tells the pituitary gland to start puberty. Once you start having pulses of release of gonadotropin releasing hormone, it awakens the pituitary gland, which then starts releasing higher and higher levels of LH, which is luteinizing hormone, and FSH, which is follicle stimulating hormone. Then these two hormones together start causing the gonads, so ovaries in girls or testicles in boys, to progressively develop and then start releasing the hormone that gonad will release. So puberty blockers look just like this gonadotropin releasing hormone, but instead of being present in pulses, is present in a elevated continuous level, or what we would call a tonic elevation. So when gonadotropin releasing hormone is present all the time, it suppresses the pituitary gland. So it almost puts a pause on that whole process of puberty. You'll see a decline in the LH and FSH levels, and corresponding to that, for a girl, their estrogen levels will go down, and for a boy, their testosterone levels will go down. So if you put a pause on puberty, then what that will do is, for girls, it will stop breast development, and for boys, it will stop testicular development and all of the things that come as a consequence of testosterone being around, which would be increase in muscle mass, lowering the voice, facial hair, increase in penis size, all of that. And then for both boys and girls, the lack of estrogen and testosterone will lead to a delay of the growth spurt that occurs in puberty. Their bones will also not mature, so they'll sort of become like a late bloomer. They'll have some time before they will go into puberty. That medication can then be continued, and depending on the treating physician, it might be continued for 1 year or 2 years, perhaps longer, but there are downsides to continuing a medication like that for a long time. So first of all, estrogen and testosterone are important for building bone density. So while a person is on a medication that's suppressing puberty, they may have lower bone density. Usually once they are allowed to go into whichever pubertal process they want to go through, they will gain that bone density back.
Right. Okay. That's important. Yeah.
And there can be some short-term side effects from these gonadotropin releasing hormone blockers, the puberty blockers. So sometimes they initially experience menopause type symptoms, some hot flashes, and some moodiness, which then kind of decline over time. And then the person has the ability to make a determination about whether they want to then just at some point stop that puberty blocker and go back to the process of development that they were in, or if they determine that they're going to transition to the opposite gender, then they may begin hormone treatment to start that transition process. So for girls that would be transitioning to males, they would be initially given testosterone in a very low dose. It's often prescribed as a topical in a gel formulation, so that it's absorbed through the skin, and the doses are gradually increased to mimic what would happen during puberty. So with increasing doses of testosterone, you would see the pace of growth picking up. You would start to see more muscle development. You would start to see more body hair in general. And then later, as the doses are higher, then the person would notice starting to have facial hair, starting to have a lower voice, again, developing more muscle and developing more of a male habitus with broader shoulders, things like that. For boys that would be transitioning.
Real quickly, Suparna, no, so would this be given, the testosterone be given in concert together with the puberty blockers as well?
Correct.
Okay,
yes.
Got it. Okay, yes. So the puberty blockers have got to continue.
Right.
Okay,
yeah.
Got it. Okay.
And then if the individual is male transitioning to female, then they would start using estrogen, again in a topical form. There are actually patches that have adhesive, and you stick the patch on the skin. It's usually applied for about 24 hours at a time, initially once a week, then twice a week, and then the doses are gradually increased. At some point, the person may go on an oral form of estrogen. And then depending on what that person decides in their transition process, there may be a surgical intervention at some point. So a male who's transitioning to female may or may not want to have any kind of genital surgery done. And I cannot speak to the kind of the numbers of how many people choose to do that, but that's certainly an option. And for girls that are transitioning to male, if they've already had some process of puberty and have had breast development, they may then choose to have a breast reduction surgery, or essentially a mastectomy, to remove that breast tissue. So there's hormonal treatment, and then there's surgical treatment.
Yeah. Okay. So that's what happens. And so I think that, as we deal with this more in the news, I think it's important that people have kind of a concept about how that process works. And thank you for your very, very clear explanation of that, Suparna. Okay. Well, listen, friends, we're going to end the conversation here today. We've been having a very interesting conversation with Dr. Suparna Jain. She's a pediatric endocrinologist here in Santa Monica, California. Suparna, thank you for your knowledge. You're a wealth of knowledge, and I appreciate your love for truth and your love for kids as well. So keep up the good work over there. How can people find you, Suparna?
I am in Santa Monica at Pediatric Consultants, and I am also at Cedars in the Pediatric Endocrinology Clinic.
Okay, and her name is spelled Jain, Suparna, Suparna, Suparna Jain. Wonderful lady. So friends, you have been listening today to the Hamilton Review, where kids and culture collide. Thank you for making us part of your day. Until next time, stay healthy and be encouraged. Bye-bye.
You have been listening to the Hamilton Review, where kids and culture collide. Thank you for allowing us to be a part of your day. Tune in again next week on Apple Podcast. Rate and comment and tell a friend.